Thank you for joining us. My name is Audrey Hassan, patient liaison for the MDS Foundation, and I'll be moderating the presentation today. As we get started, I would like to thank Acceleron, Bristol Myers Squibb, Jazz, Novartis, and Takeda for supporting this webinar program. Please note that this is a pre-recorded presentation, so the presenter will not be taking any questions. The live questions with answers opportunities for all participants are included at the end of this presentation. Today's presenter is Dr. Jamile Shammo, a hematologist and associate professor of medicine and pathology at Rush University Medical Center in Chicago, where she spearheads the MDS-MPN bone marrow failure program. She is board certified in clinical pathology, internal medicine, and hematology, and board eligible in oncology. She is also a fellow of the American Society of Clinical Pathologists and American College of Physicians, and is a member of the American Society of Hematology, the American Society of Clinical Oncologists, and the American College of Physicians. She has designed and was involved as principal investigator for many clinical trials related to chronic myelogenous leukemia, MPNs, and myelodysplastic syndromes. So with that said, it is my pleasure to introduce Dr. Shammo.
Hello, everyone. This is Jamile Shammo. I'm a hematologist at Rush University Medical Center, and I'm pleased to be here with you today to discuss the diagnosis and risk stratification of MDS. Myelodysplastic syndrome is a disease that was recognized perhaps in the earliest 20th century when physicians began to recognize that there were subset of patients that developed anemia that was refractory to treatment, and a subset of those patients went on to develop leukemia. So MDS for quite a while had been deemed as a pre-leukemic state, though understanding this disease characteristics and developing various diagnostic schema helped us understand that there's a great deal of heterogeneity in those disorders. However, they do share certain features to them. So when I think of MDS, I think of a group of hematopoietic stem cell disorders or neoplasms that result in the bone marrow inability to generate blood elements. So you end up with a form of bone marrow failure with either anemia, low platelet count, or low neutrophil count that sort of predominate the clinical picture. The diagnosis of MDS requires the demonstration of what we call dysplasia in the bone marrow. The pathologist who reviews the bone marrow has certain features that he has to identify in the cells in order to call them dysplastic, and we're going to sort of go over that at some point. And there has to be at least 10 to 15% of cells that demonstrate dysplasia, because dysplasia can occur in a variety of inflammatory or infectious disorders, but we don't want to mix that with MDS. In about half of the patients, you will see those clones that we keep talking about, meaning those cells that originate from the same stem cell. And you may be able to identify 50% of the patients who will have what we call cytogenetic abnormalities. And those are abnormalities that will also affect the prognosis and sometimes the treatments that we choose for patients who have this disorder. And if you take all patients who have MDS, the chance of progression to acute leukemia over time is up to 30%. And I will show you graphs that also show perhaps the time to developing acute myelogenous leukemia. For the most part, 90% of patients who have MDS will have what we call hypercellular bone marrow, meaning if you look to the right, this little picture shows a bone marrow that's on overdrive. It's really working very, very hard to generate blood elements, but for some reason there is arrested maturation and you don't get ultimately those blood elements to form red cells, white cells, or platelets for that matter. Now, I told you that half of the patients will have cytogenetic abnormalities, but now that we have the capability of detecting even minor changes in the human genome, and we're able to show mutations in MDS. So if you looked at that, and we'll go over some of that a little later on in the lecture, the number suddenly goes up to about 90%. So 90% of patients who have MDS will have some form of clonal hematopoiesis that can be detected by what we call next generation sequencing. So it makes the diagnosis somewhat easier in certain instances where the diagnosis isn't so clear cut, and certainly that can be the case on occasions. So how often does MDS happen? This is a list that's taken from the SEER data based in 2016. And this is sort of compares the hematological malignancies. So here's MDS, and the incidence is 4.5 per 100,000 patient, right? And then it kind of compares the survival rate compared to other hematological malignancies, and you'll see that MDS 5-year overall survival, at least in that time frame from 2006 to 2012, was only about 30%. But realize that those data change because it depends on the patient population that you are studying. And of course, when you have more treatment options available to patients, those numbers will change. But one thing for sure, though, is that MDS is a disease of older individuals, and there is no doubt that this has been shown over and over that the majority of patients who have this disorder tend to be above the age of 60. Now, granted, you have very young patients, much younger, that do develop this disorder, but the percentage is really very small. And those instances, I think you have to think about hereditary causes or perhaps prior toxic exposure that may be leading to this disease. And exposure, obviously, to certain substances, chemotherapy or radiation, can be identified in maybe up to 90% of those patients, but there will always be a subset of patients that develop MDS without any plausible explanation. This is more of an updated SEER data, and this shows you the incidence per age. And again, if you looked at the rate, it's really very low in patients who are below the age of 40. But if you looked at patients who are above the age of 80, the incidence, the rate suddenly rises to 54. And you can see the number of cases up to 12,000, almost most of them obviously in this patient population. And then if you look down by race and ethnicity, so you're looking at various races, depicted here, and the highest rate, the 4.6 number, is noted in the white population and mostly in the males for some reason. So out of 23,000 cases, 13,000 occurred in male and 9,000 occurred in female. And the reason for that distinction isn't really clear, but people say, well, perhaps males may have more exposure with work to certain substances. But again, I'm not exactly sure that we know the exact difference. More to come on that, I'm sure, with epidemiological data. Regarding the clinical manifestations, it really depends on the pace of the disease and on the severity of the cytopenias. I have had some patients who were diagnosed with MDS that have no symptoms whatsoever, but they mostly tend to have milder forms of anemia or perhaps milder low platelet count drop. So there has to be a reason. Or the other explanation is that sometimes patients who have had this disorder have had it for quite some time, and they somehow gotten adjusted to living with this disease. So in general, MDS is diagnosed after a primary care physician does a routine CBC and notes anemia or low platelet count, and then a referral is generated to the patient to go see a hematologist. At that time, they will have certain type of workup, and then you end up with a bone marrow biopsy that will show you the diagnosis. So remember, having a bone marrow biopsy is extremely important in making that diagnosis. Without it, it'd be very difficult to be certain that those low blood counts are the result of MDS. In general, when you look at all patients who have this disease, 90% of those patients will have anemia and consequences of anemia, such as fatigue, shortness of breath, and ultimately most patients will require blood transfusion so that they can address the symptoms that come out of this. About half of the patients will have low white cell count and what we call neutropenia, and neutrophils are cells that fight infection. So often patients may present actually with recurrent infections, and then someone does a CBC and they'll find that they have low white cell count, and then they'll undergo workup. Similarly, about 40% will have low platelet count, and again, the drop in platelet count varies greatly, but generally, if the platelet count is below 10,000, that's when patients may have spontaneous bruising or bleeding. But again, I've seen various levels of thrombocytopenia. Again, everybody needs to be evaluated accordingly so that a bone marrow biopsy can be done and a diagnosis can be made. When it comes to the clinical presentation of MDS, MDS occupies a central location to a variety of hematological disorders. So it could overlap with acute myelogenous leukemia. It definitely overlaps with myeloproliferative neoplasms, with aplastic anemia, with paroxysmal nocturnal hemoglobinuria. I've had some patients who have T, large granular lymphocyte leukemia, or those who have pure red cell aplasia that can also have dysplastic features. So it is extremely important for patients who have MDS to be evaluated at a center of excellence where physicians, pathologists, and other healthcare providers are capable of recognizing this entity, discriminating this disease, distinguishing it from other entities, and arriving at the right diagnosis. Anytime I am evaluating a patient who has myelodysplasia, I want to be certain that we have ruled out every other possibility that could present as such, that could cause dysplasia. So if you have a patient who had received growth factor or chemotherapy, and then you do a bone marrow biopsy, there is no doubt in my mind that you will see some degree of dysplasia. So that in by itself doesn't mean that your patient has MDS, right? So timing of the bone marrow biopsy is extremely important. Certain viruses, if you have someone who has HIV or Hep C, you certainly can see dysplasia in the bone marrow, particularly with the acute infection phase, but it could also happen later. If you have someone who has an autoimmune disorder, let's say someone has lupus and then they have a flare of their disease and very low counts, and someone does a bone marrow, it's very possible you may see dysplasia in there, but that's not MDS, that's simply dysplastic features of the bone marrow that are associated with this inflammatory condition. So those need to be ruled out as well. If you have people who have nutritional deficiencies such as B12, folate, or copper deficiency, copper happens mostly with gastric bypass, and if patients don't have supplementation, or if you have pernicious anemia and someone has B12 deficiency, and perhaps their diet isn't great, doesn't include fresh food, and perhaps they end up with folate deficiency, all those features can definitely cause not only low blood counts, but also dysplastic features in the bone marrow. So those are must exclude prior to making the diagnosis. And again, in patients who abuse alcohol, and I have seen marrows that are extremely hypocellular or dysplastic changes, again, because of extreme exposure to alcohol. So again, having an open dialogue with your physician will be extremely helpful in that regard. Now, there are other diseases, other disorders that can manifest with low blood counts, but don't necessarily mean this patient has MDS. And an example is what you see down here. And those are the disorders I kind of outlined in the prior slide that need to be distinguished from MDS. Therefore, everybody who comes to the clinic with that potential or suspected MDS needs to have a complete history and physical, understanding how many transfusions or have they required transfusion, and if so, how many. Do they have organomegaly? Do they have other vitamin or mineral deficiencies? I usually obtain a serum erythropoietin level, and it's very important to obtain that because erythropoiesis stimulating agents can be very helpful in terms of ameliorating anemia and reducing the need for transfusions, but you need to identify that level that perhaps tells you that the patient is more likely to respond based on that serum EPO level. And if it happens after a transfusion, or if it happens after someone already received EPO, well, it's not going to be very informative. So it's very important to obtain that at baseline. Obtaining certain viral testing, I usually ask a pathologist to look at the peripheral smear, look at dysplasia that may be present in the bone marrow, and then of course evaluate copper level, particularly in a subset of patients where you are concerned about malabsorptive states, celiac disease, for example, if they can't keep food down, they're malnutrition, as I already said, gastric bypass, or those who have massive amounts of zinc because they take a lot of Tums or Mylanta because they have like a very strong GERD history or gastroesophageal reflux disease, and so they will develop copper deficiency. But again, ultimately, you will have to perform a bone marrow biopsy, obtain a sample for flow cytometry, looking for blasts, and obtain a sample for cytogenetic testing to understand the prognosis and potentially treatment, and perform molecular testing, which is the next generation sequencing I told you about, looking for mutations. There are certain tests that I might ask for, FISH analysis, although it's been less and less because you should be able to identify deletion 5q on cytogenetic testing. So it's the rare instance where I don't have it on the cytogenetics and I have to resort to FISH. 512 translocation may actually be something that I would look for with FISH analysis. And then, of course, platelet-derived growth factor beta gene rearrangement may be identified better on FISH analysis, so that I would do if I have a patient in whom I'm considering those types of mutations. And of course, if you have someone who's really young, or if they have a family history of hematological malignancies, then I would consider genetic testing to identify certain forms of disorders that could be hereditary, and that would be important for genetic counseling. If you remember, I told you about the dysplasia, and to the left is an example of white cell dysplasia. So those cells don't have enough granules and they have fewer lobes in them. To the bottom left are a collection of blasts, and that actually could make the diagnosis a little easier because the identification of blasts is perhaps more confirmation that this is a malignancy, a clonal disorder. To the right is examples of red cell dysplasia, and that little bottom right is an example of certain red cell precursors that have those blue dots around the nucleus, and that means that all those blue dots represent iron, and this is what we call sideroblasts. The presence of sufficient amount of sideroblasts in the bone marrow is what we call sideroblastic anemia. The exact reason for inability to utilize iron, which is all those blue granules, has not yet been identified, but granted, there had been specific mutations that associate with this type of phenotype, and those mutations are also identified on the next generation sequencing or the molecular analysis. On the bottom is what the megakaryocytes or the platelet precursors could look like under the microscope, and you can see they are very, very abnormal looking. The bottom left is just an example of very small megakaryocyte or a platelet precursor, and it almost appears like it's in the peripheral blood. So the pathologist will look at those changes and then make the diagnosis together with looking at the cytogenetic testing, etc. Now, MDS is a very complicated disorder. This is just an example of what the World Health Organization put together in 2016. And you can see that you have various subtypes that we have to kind of think about our patient and correlate the findings with what we have. So you see that you need to demonstrate the dysplasia in either one lineage, 2 or 3, and the more lineage that have dysplasia, the higher the risk may be, or perhaps you may be able to identify the exact subtype. So it's either single lineage dysplasia or multi-lineage dysplasia. And then, of course, you have to identify ring sideroblasts, and then you can see the list goes on relative to the presence of blasts in the peripheral blood or the bone marrow. And there had been some changes in that there are certain cytogenetic abnormalities that do not necessarily define MDS. So if you have deletion of chromosome Y, well, that doesn't necessarily identify this disease, or trisomy 8, that doesn't define the disease. Be it as it may, pathologists will rely on this classification so that they can arrive at the appropriate MDS entity. Okay, but now what about prognosis? Yes, there are certain things that we derive from MDS WHO classification, but when it comes to living with this disease and what does it mean for survival and perhaps the potential for developing acute leukemia, well, that's when the international prognostic scoring schema became important for us as physicians, so that we can sit with the patient and explain what their risk for survival and the chance of developing leukemia. And that's where the IPSS comes from. And this score originated from evaluating a very large number of MDS patients who had various clinical characteristics, and they were kind of followed so that the physicians can follow them and see which feature that they had from the get-go, from the baseline, that correlated with the worst outcome. So in that prognostic model, it was clear that patients who had higher percentage of blasts, and they would be assigned a particular score. So if you had no blasts in the bone marrow, well, then you had no score at all, right? If you had 11 to 20% blasts, then the score was 1.5 for that particular feature. Then the karyotype, meaning the cytogenetic abnormality, and you have 3 different types. For example, patients who have complex karyotype, meaning more than 3 separate clones, then they got 1 point added to the score. And then also, it depends on the type of blood count abnormality that you have. So if people have a hemoglobin, let's say, below 10, then they, as the only abnormality they had, then they also got a 0 variable. Those who have more than one cytopenia, perhaps low platelets and anemia, then they had the 0.5. So a hypothetical patient who may have 15% blast, poor karyotype, and 3 cytopenias, all of a sudden will have 3 as their IPSS. And that means, if you looked at the total score list down here, that this is a high-risk disease, essentially, with short median survival of about 0.4 year, in essence, less than half a year, right? So, but I like to say a few things about the IPSS in that, first of all, it chose patient population that was not treated. Anyone who used chemotherapy, anyone who has therapy-related disease was simply taken out of the equation. And it also did not take into account any of the treatments that we have available for MDS patients right now. So when you think about median survival, you have to keep in mind that this reflects the natural history of this disorder. Those weren't patients that received any treatment. And also look at the publication date, 1997. So I think I can say that we have drugs right now that will definitely improve patients' survival. So that's actually a positive note to think about. And also, we have to realize that this was constructed before your 2016 WHO, before the changes that happened in the classification of MDS. So it includes patients who had up to 30% blasts, and that is now considered low blast acute leukemia. So perhaps a difference in the way we characterize those disorders, but in terms of the tendency for them to evolve or grow is only a change of category as opposed to a change in the biology of this disorder. But be it as it may, this is how the IPSS falls in terms of frequency of the categories. So you'll note that the majority of patients had low to intermediate 1 risk, whereas a smaller subset, perhaps a third, had intermediate 2 and high risk disease. And those patients typically are characterized by higher blast percentage and poorer risk cytogenetic. Okay. So it was clear that we needed a revised IPSS. Why? Because again, we have a different classification schema that consider anything over 20% blast acute leukemia. And we also recognize over the years that the nadir of the blood count matters. So you cannot lump together someone who has a hemoglobin of 9.9 and someone who requires transfusions every 1 to 2 weeks. Their prognosis is certainly different. So the IPSS revised looked to include features that matter to prognosis. Furthermore, the German-Austrian group looked at over 2,000 patients and refined their cytogenetic categories. So now we have 5 different categories, not 3, like we did in the IPSS. So here, this is a more refined scoring system, and it actually will identify patients who may have been previously identified as low-risk disease, but now you can include them in perhaps a higher risk group, and you can think of their progression and perhaps treatment options a little bit differently. So take, for example, the patient that I had told you in the prior example, right? The person that had blast count over 10%, so they get a 3 score. If they had a poor karyotype, now they have a much higher prognostic variable with the cytogenetics, let's say another 3, so that's a 6. You're already thinking about high or very high risk disease, and you haven't even gone through the neutrophils or the hemoglobin, etc. So I think, generally speaking, the IPSS revised is what we are utilizing right now with enrolling patients onto clinical trials and even in day-to-day practice. Those are the 5 different groupings that I had talked to you about that were incorporated into the IPSS revised. And here you can see that deletion Y and deletion 11q. So those are certain parts of the chromosomes that are missing, right? And that's what identifies a very good risk group. Now, in a good risk MDS normal karyotype, is considered a good risk. Deletion 5q, and again, that's a loss of a small part of the long arm of chromosome 5, is also considered a good risk, particularly when it occurs in isolation. And you can see the list again goes on. And we do recognize that patients who have more than 3 abnormalities, it's really difficult to treat those patients. Because anytime you have complex karyotype, it associates with other genetic lesions that associate with resistance to therapy. So I think we need a different way to think about those abnormalities and how we can treat those patients better than we are right now. So this breaks patients in this over 7,000 patients Dr. Greenberg looked at for the IPSS revised into 5 different groupings with very different median survival and percentage of evolution to acute leukemia. In the very low risk, you can see the median survival is about 8.8 years, and again that varies from 8 to 10 years. And then if you looked at the very high risk group, that is over 6 points, and here you're talking about 0.8, so not even 1 year. And so those patients really need to be evaluated for stem cell transplantation whenever that is feasible. So, and to the right is the acute leukemia evolution, and you can see the risk of leukemia evolution in patients who have very low risk disease, let's say at 10 years, is really very low. Whereas when you look at patients who have higher risk score, the development of acute leukemia is certainly higher. So that, but one point though I do want to say is that, yes, it is kind of worrisome to think about acute leukemia, but generally speaking, it's the bone marrow failure that results in grave consequences in this, whether or not acute leukemia developed. Why? Because the low counts predispose patients to infection or bleeding, and that is the concern. One other scoring system that I hadn't discussed was the WHO-based prognostic scoring system, which includes the need for transfusion, and again, that's something that was not incorporated into the initial IPSS. So this system was actually evaluated in a subset of patients who had undergone transplantation and were stratified by the WPSS, and you can see that their overall survival as well as progression-free survival was nicely stratified by the WPSS category, essentially telling you that transfusion dependency matters even in the setting of stem cell transplantation. But we don't, for some reason, utilize the WPSS in the States. But again, it's the only scoring system that requires transfusions. I do think that if you utilize the IPSS revised, as it does have a category for patients with a hemoglobin below 8 grams, so maybe that incorporates transfusion dependency in that. Once the human genome was completely sequenced, then the ability of physicians, molecular geneticists, to identify certain mutations in all aspects of the chromosome became possible, it became feasible. So this is the initial work that utilized next generation sequencing to look for mutations beyond the cytogenetics. So the cytogenetics is one test, and next generation sequencing is another that looks at particular mutations that you wouldn't be able to detect otherwise. And in that analysis, they looked at over 400 patients, and they identified, I want to say 80% of the patients in that paper had one genetic mutation or the other, and some had more than one mutation in that. So they were also able to identify an association with poor outcome should the patient have specific subsets. So let's say ASXL1, the identification of that mutation correlated with the worst prognosis. TP53, definitely worse outcome. And the rest goes on. You can see all the ones that have less than 0.001 percentage is essentially statistically significant and means that this mutation is associated with the worst outcome or worse survival. Now, one interesting caveat is that ASXL1 is a mutation that could be identified in older individuals. The older we get, whether or not we have MDS, right? So again, is that a marker of aging? Is that a marker of worse outcome with treatment, cardiac risk, etc.? It's really, again, we're just probably scratching the surface of the knowledge that could be gleaned from all those mutations. But be it as it may, in that analysis, Dr. Bahar showed in the A panel, for example, that patients who have low-risk disease in that little solid black line, and you can see their outcome relative to the survival, compared to the intermediate 1, 2. So granted, you can see the risk stratification as you would have expected in the IPSS, right? But now you look at the survival relative to the presence or absence of the mutation. This is panel B, and you can see that patients, even though they may have the exact same IPSS scoring, have a difference in outcome should they have mutation presence versus absent. So, okay, well, maybe that pertains more to higher risk categories. Well, that's not the case, because even in the lower risk category, as you see in panel C, where you have lower risk mutation without any demonstration of a mutation, that is, compared to low risk with the mutation present in that fenestrated line, you can see that the outcome relative to overall survival is also different. And all of a sudden, the outcome of those patients overlap those who had intermediate 1 risk category. So essentially, the presence of a mutation ups the risk score from low to intermediate 1. And similarly, in panel D, patients who have intermediate 1 that have a mutation, now in the dotted line, their prognosis or overall survival matches that those patients that have intermediate to risk scorings. Again, the point is to say that the presence of a mutation perhaps upgrades the risk category, which is why we do next-gen sequencing on every patient who has myelodysplasia at baseline and perhaps at certain points during their treatment. Now we learned, and this is again a much larger scale of analysis of patients who had MDS, because now they looked at a much bigger set of genes as opposed to the initial 40 genes. So now you can see the incredible complexity of this disorder. So this shows you all the mutations that had been identified in this subset of patients, SF3B1 being the most common, and that's kind of relevant because it identifies a particular subset of MDS patients known as, this is an older but basically is what you see with patients who have ring sideroblasts. And these mutations are not particularly specific for MDS. You could see them in other disease entities, in overlap syndromes, in MDS MPN. But again, SF3B1 is one of the most common ones, and it can be associated with refractory anemia with ring sideroblast. But I think looking at this graph makes you sort of amazed by the complexity of this disorder and the fact that our treatment offerings right now kind of ignore the incredible heterogeneity, the molecular heterogeneity in this patient population. And I think only by enrolling patients on clinical trials that are evaluating new agents, new combinations, will we ever understand what this means in the long run for patients. And also, by monitoring those mutations moving forward, like as the disease progresses, let's say after a given treatment, and then you can look at the genomic landscape of that particular disease in a given patient to understand what would be the best next option. I do think we're far from that, but this is a very good starting point, I have to say. So now we can understand the prognosis associated with certain mutations. I told you about SF3B1. It's definitely a very good mutation to have. It's typically associated with ring sideroblast, and in general, what we know about refractory anemia with ring sideroblast, although that's the older term, is a milder disease associated with a favorable prognosis, and so this is a good mutation to have. TET2 mutation can be associated with potential response to hypomethylating agents. And it2 is one of the more common ones that can happen. And all the rest are mutations that may have been associated with the worst outcome, and I kind of touched upon that from the previous paper. And now that we actually can identify certain mutations in patients, it was very interesting to see that there are some individuals who have a completely normal blood type, but they do have certain clones. And these could be identified by, again, performing next-generation sequencing. Clearly, nobody would run a next-generation sequencing panel on a normal individual. These happened to be research endeavors that identified those clones in people who have normal CBCs, essentially, and wouldn't necessarily be tested accordingly. But it helped us understand that perhaps this is how MDS originates. And isn't it interesting that in the beginning I told you that MDS precedes leukemia, but now we are identifying lesions that precede MDS. So we label those as clonal hematopoiesis of indeterminate potential, meaning or CHIP. Okay, so if you ever heard CHIP, that means it's a patient that has normal blood counts, but they have certain clones that are identified on next-gen sequencing. This disease could ultimately, progress, and ultimately those patients may develop cytopenias. And the assumption is that you do have more clones that affect the hematopoietic stem cells by those little dots that you see, to the point where the bone marrow now is incapable of generating a completely normal blood count. So now you have clonal cytopenias of undetermined potential or significance, if you will, because now they're clonal, but perhaps you don't need a transfusion. You don't even have the ability to make a diagnosis of MDS for that matter. But again, in time, if those lesions continue to grow, well, now you get to what we label as a myeloid neoplasm. And now, if you did a bone marrow biopsy, you should be able to demonstrate dysplasia and perhaps be able to make a diagnosis of not only MDS, but of a given myeloid neoplasm. So this is sort of a futuristic way of thinking about it. And I always look at this and think, like, we're supposed to probably think about what causes the development of those mutations much early on and think about ways to eliminate that. And there will be work that will be addressing those perhaps certain endeavors in that regard that will be coming forth soon. So this is a little bit more complex, perhaps, to show you exactly how you go from the traditional idiopathic cytopenias of undetermined significance, which include the CHIP and CCUS, to moving forward to MDS or other myeloid malignancies. Now that we have talked about the prognosis, I'd like to say a few words about the treatment principles. And every time I see patients who have MDS, there are no two patients alike, granted. Why? Because everybody has their own set of treatment preferences, their own philosophy, let alone their clinical characteristics and genetic mutations, etc. But broadly speaking, we have a curative approach and a non-curative approach. So the curative approach means that your patient is fit and capable of undergoing allogeneic stem cell transplantation, which is the only curative modality. Generally speaking, this modality is considered for patients who have high-risk disease. I'd shown you the survival and leukemia evolution in this group of patients, though it's not to say that we wouldn't consider this in patients who have low and intermediate risk categories, particularly if they require a lot of blood transfusions, because that would be a patient I would consider. But generally, it's considered on a case-by-case basis. But for the most part, people who have low-risk disease are considered for transplantation at the time of disease progression, which is why we like to monitor them pretty frequently. And I might add that transplant evaluation for patients who may be fit for transplant is something that we'd like to do early on in the disease course, because undergoing transplantation takes a long time to identify a donor and go through the process. And so granted, this is something we like to discuss with the patient much early on in the process. So if that's not an option, then non-curative approaches are what we rely on. And there you have various categories. You have supportive care with growth factor, transfusions, and antibiotics when you need them. And that represents the cornerstone of management of MDS and supportive care in this setting. Now, obviously, if you have a patient who has certain disease characteristics that will help you with choosing the treatment, for example, if you have deletion 5q, then lenalidomide is the drug of choice. If you have a patient who has ring sideroblasts and anemia and requires transfusions and a very high erythropoietin level, in which case you can't even use erythropoietin to improve their hemoglobin level or anemia level, then luspatercept is a drug that was recently approved for the treatment of this patient population. Now, hypomethylating agents have been utilized, and azacitidine has shown improvement in survival. Decitabine is another very reasonable agent that can be used in patients who have intermediate and high risk disease, and I'll show you some data about that. And just about a week ago, there was an oral hypomethylating agent that has been approved for the treatment of intermediate to and high risk disease. And that represents an exciting development for patients because it will avoid the need for infusional treatment with AZA or Dacogen. Induction chemotherapy can be utilized in younger patients who have a proliferative disease and may be fit for stem cell transplantation. I might consider that in a subset of patients. But for the most part, we rely on hypomethylating agents, again, because of the age of the patient population that has MDS. But again, it's a choice that you have under certain circumstances. In general, though, whatever we are utilizing, the idea of treatment for MDS is to improve the patient quality of life. How do we do that? Well, if someone is requiring transfusions, my goal is to cut down on that transfusion rate. If I can eliminate it altogether, that's fantastic. If I can reduce it, I would consider that a win as well. If I can improve somebody's platelet count and neutrophil count, so I can reduce the risk of bleeding and infection, absolutely, this is what I will try to do. Now, granted, every chemotherapy that you use will result in some degree of low blood count, so I don't want the patient to be disappointed that, my counts are even lower than I started out with. Well, remember that is sort of a given because it's iatrogenic, it's treatment induced, and at some point, 3 cycles in the case of lenalidomide, perhaps 4 to 6 cycles in the case of azacitidine, you have to give it time to assess whether or not this treatment is working. So there is a price to pay in the earlier phase of treatment so that you can reap the benefits of treatment later on. So ultimately, if the drug results in improvement or control of the disease, you should start to see improvement in the blood counts, perhaps reduction in transfusion requirement. If that's not the case, then I think at some point in time, the patient needs to be reevaluated. And this is basically an algorithm as to how we think about MDS therapy. So you do risk stratification, you do the molecular testing, and if you have a patient that has asymptomatic and lower risk disease, I'm perfectly okay observing them until they progress, because there has not been a single evidence in the literature to say that earlier treatment is better for those patients that have no symptom, okay? So we have to be cognizant of that. For patients who have lower risk disease, it depends on the presence or absence of certain disease characteristics. So if they have DEL5, it's lenalidomide. If their EPO level is below 500, then erythropoiesis stimulating agents is reasonable. If they have high erythropoietin level, then luspatercept could be reasonable. Hypomethylating agents, immunosuppressive therapy is another thing we didn't even touch upon, would be something to consider. If they have severe cytopenias and low-risk disease, certainly stem cell transplantation could be considered in this instance. If you have higher risk disease, like I already told you, you have to consider transplantation, and if the patient is not a transplantation candidate, then non-transplant options, as we discussed, would be the way to go. Transplantation for MDS is certainly what we like to think about in patients who have high-risk disease, and we think it's the only curative option. However, in this study, remember the 4-year estimates of overall survival are only about 31%. So relapse can occur after transplantation, and certainly death from either the treatment itself or consequences of it also is an issue related to transplant. So perhaps non-relapse death and relapses are being addressed in various approaches when it comes to transplantation. So, but I kind of want to be realistic about that option, is that if it were 100%, I think we would be having a different and stronger recommendations for perhaps everybody, but that isn't the case, and you have to consider risk of relapse, the risk of treatment-related morbidity and mortality. And what about the impact of certain mutations on the outcome of transplantation? And here, if you remember the TP53 that I had told you about, this seems to be a driving factor when it comes to outcomes of transplantation. So in this analysis, Lindsley and others looked at the outcome of over 200 patients who had undergone stem cell transplantation and looked at their molecular landscape at the time of the disease and prior to transplantation, obviously. So you can see that they have various set of mutations as depicted in the top panel. But when it comes to their overall survival in panel B, note the difference in survival in those who have the TP53 mutation versus those who don't have it. So even within that same subset that undergone transplantation, the presence of this mutation portends for a much worse outcome, even though you are offering the best treatment there is. And you might say, well, maybe this has something to do with the age of the patients. Well, panel C looks at the age together with the mutational status. And it would appear, if you looked at the red lines, that those who have TP53 mutation, whether or not they were below the age of 40 or over the age of 40, their outcomes were sort of the same with stem cell transplantation, with kind of a close to maybe 20% survival rate. So I think we need to tackle TP53 differently, and there are investigational agents that are being looked at in various combinations, mostly with hypomethylating agents, to overcome this particular abnormality that can be identified. So even with transplantations, mutation can govern prognosis. Ever since azacitidine became available based on the azacitidine survival trial, which demonstrated that you have almost like 9 months difference in survival when patients were randomized to azacitidine, so 15 months for conventional care regimens and 24 months for people who received AZA. I think this sort of became a cornerstone of treating intermediate to and high-risk disease patients, and those are the responses. I want to show this to kind of explain that not everybody responds to hypomethylating agents, right? So if you looked at the response rate, I mean, you're talking about 30% that have complete response and partial response in the AZA arm, and maybe 12%, and that includes chemo, low-dose Ara-C, etc. And the difference was statistically significant between the two. If you looked at hematological improvement in the second graph, you can see, again, 49 versus 29%. So half of the patients will have their counts improve in some way, but it's, again, not 100%. And so combination studies became sort of the rage in MDS, and in the beginning, it was kind of interesting to put those together. And why was that important is because the outcome of patients who had failed azacitidine, as depicted in this paper, was not very good. And we still don't have a good second line for patients who have failed azacitidine. So, of course, the best outcome was that for those who were able to undergo transplantation or go on to investigational treatments. But that may have a selection bias in it, in that patients who have the best performance status, perhaps a more chemosensitive disease, were the ones who were treated accordingly and had better outcomes. So that's why we like to think of combination to perhaps improve the outcome, prolong response rates, and reduce the chance of disease recurrence. In this study, people compared the SWOG, actually a Southwestern Oncology group, looked at azacitidine versus combination of azacitidine and lenalidomide, or azacitidine and vorinostat. Again, why? Because the combination of those agents looked very promising in phase 2 studies. So phase 3 study came about to say, okay, well, is the combination better than the single agent? And here you see the outcome in terms of survival, and there really was no difference whether you used AZA alone versus lenalidomide or vorinostat. So, but I don't think that this should stop our appetite for combination therapies, because I can tell you, looking at European Hematology Associate meeting or the most recent ASH, there are very promising combination therapies that are going on in clinical trials, and we should consider participation in that. On a positive note, there are multiple agents that are being considered for the treatment of MDS, either as a single agent or in combination with hypomethylating agents. And you can see the list that seems to be very promising. In fact, the drug I had already alluded to, which is an oral hypomethylating agent, has been recently approved by the FDA, which should hopefully contribute to improving patients' quality of life, because they will now receive their treatment as a tablet as opposed to needing to go to infusion and receive their treatments accordingly. APR-246 is the drug I had mentioned that has very promising results with TP53. Pivonidostat is a drug that had been studied in combination with azacitidine in a phase 2 study, and that too showed improvement in event-free survival for patients who received the combination. Venetoclax is being studied in combination with azacitidine in patients who have intermediate and high-risk disease, and we have a trial that's about to open with the combination. So the point is that these are very exciting times for physicians and for patients to seriously consider participation in clinical trial, because this is the only way that we can get drugs approved for this patient population and furthermore understand a little bit more about the disease biology, which I think truly is what we need to understand how to treat this disease and make patients live longer. So I hope that I had given you an overview on what MDS is as a disease, how difficult it can be sometimes to make a diagnosis and distinguish this disease from other entities, and how difficult it is to actually choose a particular treatment for patients who may or may not have a particular disease feature that can help identify a better treatment for them. We continue to think about risk stratification as a better assessment beyond pathology to be able to tell the patient their prognosis and what type of treatment they should be receiving. We continue to think that growth factors, lenalidomide and luspatercept, should be considered in patients with low-risk disease. Hypomethylating agents should be first line of therapy for higher risk disease. Stem cell transplantation should be considered from the get-go in all patients who have this disorder, and a referral should be considered again early on in the disease process. Realize that there's no standard of care right now for relapsed refractory, although again this hypomethylating agent, the oral drug, could be utilized in this setting. That we have several novel agents that are being explored in relapsed refractory disease and multiple other trials that are being explored in upfront treatment of MDS. So it would be interesting to wait for the confirmatory trials that will confirm the positive outcome that is gained from combination therapies in the treatment of upfront MDS when compared to standard of care. So I thank you all for listening, and I look forward to receiving your questions.
Thank you, Dr. Shammo, for your wonderful presentation. Great talk and very thorough overview of the disease landscape and emerging treatments. We have our first question from Diane. Do you know anything about your copper being too low? I was diagnosed with MDS in March of this year and went to the University of Minnesota, where they said my hematologist should check my copper level. Thus starts my journey with MDS, and instead of doing chemotherapy, I am now doing copper pills.
I couldn't agree more with, and I'm in a way very pleased that the diagnosis was copper deficiency as opposed to MDS, a chronic disease that has serious consequences on longevity versus a mineral deficiency that could be addressed. So we've seen a couple of cases actually with copper deficiency that had been diagnosed as MDS in error, because copper is a very important molecule that is an integral part of various enzymes that are important in hematopoiesis. So in the metabolism of B12, in the metabolism of iron, you have copper as an important mineral in some of those enzymes. And so if it's missing, it's going to make it look like either B12 or iron deficiency and provide some dysplastic changes, though there are some features to copper deficiency that could be seen by morphology, and that is sometimes those erythroid precursors, the red cell precursors, can look vacuolated. And then, of course, most importantly, the medical history about things like gastric bypass, or even someone may have neurological symptoms, could also be supportive of that. But the way to make the diagnosis is by checking a copper level. So that, again, it's not a very common condition, but it certainly is one that we need to think about to distinguish it from MDS. I'm pleased that actually I'm hoping that the blood counts and the symptoms the patient had got better with copper supplementation.
Thank you, Dr. Shammo. The next question comes from Fred, an MDS patient with ring sideroblasts. He has a question regarding his CBCs, his complete blood count lab reports, in particular related to his red blood cell counts. He wants to know if the counts reflect only healthy mature red blood cells, RBCs, or does it also include those that are irregular, that are dysplastic or not healthy?
So it's a good question. I think that when you think about the CBC results and you're looking at the hemoglobin, the assumption is that this is made from cells that mature correctly or accurate, or I should say appropriately, and lead to formation of red cells. So when you have ring sideroblasts, there's an arrest in maturation. There is no formation of red cells, essentially. But I would like to think that the CBC reflects the cells that are in the bone marrow that are not affected by this ring sideroblast mutation or abnormality. So you still have a subset of normal cells in the bone marrow that are making red cells to some extent. I hope that answers your question.
Thank you, Dr. Shammo. The next question is from Patricia. What role do somatic mutations play in prognosis?
So that is something that we are addressing moving forward and trying to understand what is the impact of a particular mutation or even the number of mutation on outcome of a particular therapy. You're probably going to start to see that the treatment that we have is shifting somewhat towards targeted therapy. There's a great deal of interest in developing treatments that target particular mutations. And so I think that's how treatment paradigms for MDS will happen in the future. Right now, all we know is that if you have certain mutations at baseline, that the outcome may or may not be associated with that, right? We know that there are certain mutations that affect prognosis negatively. I've already outlined some of those. But how do they figure into treatment response? I think that's what we need to see moving forward with treatment. I've shown you results of transplantation relative to TP53 mutation, right? So that's kind of interesting to see what does a particular treatment do when you have a particular mutation present. So now that you have certain treatments that are targeting TP53, again, it'll be interesting to see, do you get better responses in that? Is there impact on survival? What about transplant outcomes relative to this? So everything is going to be shifting towards targeted treatment, looking at particular mutations and the outcome, and also patterns of relapse when you have those types of mutations. So it's going to be like a whole new science, if you will, once we have more information with targeted treatments.
Thank you, Dr. Shammo. The next question comes from Ronald, who has the DNMT3A and SF3B1 mutations, and he wants to know how does that affect his prognosis.
So I think the presence of SF3B1 makes for a better prognosis. DNMT methyltransferase A mutation is a very common mutation in MDS, and that's in a way what I was trying to say about the impact of multiple mutations, right? So the presence of a mutation is one thing, but having more than one, and also what about the CBC results and what about the cytogenetics? So I think all that has to be put together. Now, the American Society of Hematology, as well as the various MDS investigators are looking to incorporate the molecular diagnostics or molecular mutations into the risk scores that we have now available to us. So I still think that it's important to put all the risk scores together and then add the mutations onto them to see if there is any particular effect that culminates from combining all of that together. So more on that to come, I'm sure.
Thank you, Dr. Shammo. Great answer. The next question comes from Phil. My tests show no gene mutation, but there are low blood cell counts and 6% blasts in my bone marrow biopsy. Is it MDS or could it be something else?
Well, you have to, the presence of increased number of blasts essentially means that there is a clonal population of cells, because really having more than 5% blasts, having more than 2% actually by the IPSS is not normal. So there is a myeloid neoplasm going on. Whether or not this is MDS depends on the degree of dysplasia and how much, what type of cytogenetics exist. I have to say that the recognition of dysplasia can be very subtle at times. So again, having 6% blasts, that's not normal, but without looking at the bone marrow and recognizing the degree of dysplasia, it's going to be difficult to categorize this disease. So I would have to know a little bit more about it before I can say this is MDS.
Thank you. The next question is, in MDS, does luspatercept maintain hemoglobin at the existing level to keep it from going any lower?
Well, luspatercept actually can improve the hemoglobin and reduce transfusion dependency in up to perhaps 40% of patients that had received this treatment. And these were based on the numbers I'm quoting you, based on the results of the clinical trial that compared the drug to supportive care, essentially. So I guess you could say that response rate to luspatercept may vary. And at best, I should say in the best category, it will reduce transfusion requirements, right? But in MDS, we all learned that maintaining the hemoglobin, and again, we're talking about the level of hemoglobin that you started out with, that I don't know. But even if you maintain somebody's hemoglobin, let's say at 8 or 9, and now they're not requiring transfusions, furthermore, it's not dropping further, that I consider a reasonable response. Because in MDS, the sort of the understood trajectory is only progression. So if someone is not transfusion dependent, ultimately they will become one. Someone who may not have blasts, ultimately they may develop blasts. So having a steady state of hemoglobin in the presence of treatment, to me, is considered a reasonable response. Of course, I would like to reduce transfusion dependency. That would be best.
Thank you, Dr. Shammo. Fred weighs in with another question. If there is no iron overload problem, would it make sense to first raise a very low hemoglobin count through blood transfusions before receiving luspatercept to help me maintain a better level of hemoglobin and avoid shortness of breath?
I agree. I think if someone has very low hemoglobin value, that they are having symptomatic anemia, I don't think that transfusion is unreasonable. I think the reverse, it actually would be very reasonable to give transfusions to improve the hemoglobin instantaneously and relieve the symptoms of fatigue. I'm in agreement.
Thank you, Dr. Shammo. Next question from Ellie. Can you acquire more mutations as your disease progresses?
Absolutely. That's a very good question relative to the biology of the disease. In fact, initially, like when we didn't know anything about mutations many years ago, we looked at the cytogenetics as proof that this disease has progressed. And we call that clonal evolution. Essentially, the clone evolves into something else. So now, if you started out with normal cytogenetics, then you develop an additional cytogenetic abnormality, that was sort of a proof that this disease has progressed. So now with mutation knowledge, we also learned that when the patient disease progresses, you can actually acquire additional mutations. So you have a founder mutation, which is the initial one, and then many others that start to grow in that setting when the disease progresses. So you see, this is a dynamic disorder, and that in a way makes the difficulty in understanding the prognosis relative to the prior question I received when you have one or two mutations. So more data, longitudinal data to see how those mutations evolve with time or with certain treatments and how do they affect prognosis is extremely important.
Thank you, Dr. Shammo. The next question comes from Ronald. He may have missed whether or not del13q is listed on any of your graphs, and can you share any information on that chromosome deletion?
That's another excellent question. I actually think that deletion 13q should be included, and I have not seen it in many other prognostic categories. And I am aware of certain, I want to say, European papers that have talked about the importance of identifying deletion 13q. Why? Because patients who have it, even though it's very rare, can actually respond to immunosuppressive therapy. And I have several patients that had deletion 13q and responded beautifully to immunosuppressive therapy. So I think this is sort of unrecognized for some reason, and it has to be added to our current prognostic schema. And maybe we need to gather more data on this patient population so that we can confirm whether or not immunosuppressive therapy works. But like I said, in the maybe 10, 12 patients that have been reported in the literature, the majority responded to immunosuppression. And realize there are gradations to immune suppression. You can start out with cyclosporine, but the ultimate immune suppression is a combination of anti-thymocyte globulin as well as cyclosporine. And so I sometimes might start with cyclosporine, and then if there's no response, I might add ATG to it and to see if you can glean a response. And meanwhile, you monitor the patient moving forward with bone marrow biopsies to see if there was actually disease evolution, clonal evolution. Did they acquire an additional cytogenetic abnormality? Most of the patients that I've had with deletion 13q tend to have another autoimmune disorder that either was recognized or not recognized, but that is in a way part of the bone marrow failure because it's induced by some T cell attack on the bone marrow, and that's why patients end up with cytopenias. But yes, thank you for asking that. That's kind of an somehow rare disorder, under-recognized, perhaps not included in the schema that we have nowadays.
Great information. Thank you. The next question is the combination of Vidaza and venetoclax a proven therapy, or is this combination still in clinical trials?
Excellent question. Well, this combination with venetoclax and azacitidine was initially studied in patients who have acute leukemia, right? So, and the initial study, the phase 2 study, looked amazing because the response rate that patients with leukemia had to the combination was on par with what you saw with induction chemotherapy. And that was not something that we had ever seen before, to use low-dose chemo plus venetoclax. So that's why this combination became approved by the FDA, or feasible or possibly to obtain in people with leukemia. But when it comes to MDS, that has not yet been shown. I know that there are some people who are using the combination off-label in MDS, but I think the confirmatory trial is ongoing right now. And the question is, how much venetoclax? What are the cytopenias? What is the response rate in patients who have MDS? Is it similar to what we have in AML? I suspect in people who have intermediate and high-risk disease, it'll probably be confirmatory. But I think we need to know how much venetoclax to give So it's not the same like it would be in acute leukemia. It's much lesser dosing, and that combination needs to be explored still in clinical trials for MDS.
Thank you, Dr. Shammo. Next question. But
I am hopeful, if I may interject. I'm hopeful that it will be a positive trial.
Thank you once again. The next question is, what is the correlation of MDS/MPN?
So that's actually an overlap. It's an overlap disease category that was generated by the most recent WHO. I want to say it started out in the WHO 2008, and then again kind of improved upon in 2016 classification. And why was that created is because pathologists noted that there is a subset of patients who have MDS that don't only have dysplasia. Okay, dysplasia is one thing, but I also have proliferative features to their disease. So like they may present with leukocytosis, too many white cells, not fewer, or they may present with too many platelets. Well, that's not necessarily low blood count, that's high blood count, right? So it's proliferative, and yet you look at the bone marrow and you see dysplasia in there. So a disease like chronic myelomonocytic leukemia, a disease like refractory anemia with ring sideroblasts and thrombocytosis, those are considered overlap syndromes, and they have features of both dysplasia as well as proliferation. And those entities actually, it's really difficult to come up with the perfect treatment for that. Why? Because a lot of the clinical trials that took place previously did not necessarily account for that distinction. So or nowadays, for example, if you have a clinical trial that's looking at MDS, it may exclude patients who have CMML in it. And so it's really hard. And in patients who have this overlap category, it's highly patient driven. And I will do a next-gen sequencing to see if I can identify a particular mutation that may be targetable by some treatment combination I may have. If I have a patient who has CMML and a lot of leukocytes, monocytes typically, that have features of myeloproliferative neoplasm with constitutional symptoms, etc., well, maybe I will treat it one way. Or if they have anemia, transfusions, features of bone marrow failure, I may treat it as MDS. See what I mean? So it's, again, once our clinical trials account for those disease states and incorporate them differently, then we'll be able to have more treatments that are aligned with the diagnosis.
Thank you. The next question is, you said the timing of a bone marrow biopsy is extremely important because dysplastic features can exist in the bone marrow of patients who have had prior chemotherapy or growth factors. Could you tell us more about the timing? When is the best timing for the biopsy?
So I think that's probably less operative in newly diagnosed patients. Most of them may not have received prior chemo, or unless they have some other solid malignancy and they had received chemotherapy. So generally, when people receive erythropoiesis stimulating agents or Neupogen prior to having a diagnosis made, and then they undergo a bone marrow biopsy to evaluate the cytopenia, then it's really difficult to distinguish both. So my advice to the physicians is that if you are able to obtain a bone marrow biopsy prior to initiating growth factors, prior to giving someone chemotherapy, that would be the perfect time. Because once you've received growth factor, there may actually be changes to the way the bone marrow looks that may make it harder. And I realize this is only one way to make a diagnosis, right, which is morphology. But you still have the ability to obtain cytogenetic testing. You still have the ability to do flow cytometry when you do the bone marrow. So at times, choosing the appropriate time may be difficult, right? Especially if you have someone who has low white count or low counts, period, and you don't have a good diagnosis. So you may have to bite the bullet and do it. But if it is at all possible to do the bone marrow prior to exposure to either one of those, that would be my preference.
Great answer. Thank you, Dr. Shammo. John has weighed in and asking if you could weigh in on the use of Jakafi in the treatment of MDS MPN patients.
I'm sorry, I missed the name of the drug.
Jakafi, Jakafi.
Jakafi, yes. So ruxolitinib or Jakafi is basically a JAK inhibitor. JAK is a mutation that tends to be prevalent in patients who have myeloproliferative neoplasm, and the drug is approved for the treatment of primary myelofibrosis, or suppose secondary myelofibrosis after polycythemia or ET, so any form of myelofibrosis, as well as those patients who have polycythemia vera that had not responded favorably to hydroxyurea. Any other use outside of those two indications is off-label. I am aware of various clinical trials that are looking to evaluate the role of ruxolitinib or Jakafi in patients who have MDS MPN overlap syndrome, but again, this is a clinical trial, and it would be interesting to see what the response rate is, what the toxicities are, what the doses are relative to what we use in MPNs such as myelofibrosis MPV.
John, who has an MDS MPN diagnosis, now wants to know, what is the best treatment for high transfusion rate?
Well, I think I would need to know a little bit more about that. I mean, usually if you have low erythropoietin level, then I think erythropoiesis stimulating agents would be one way to go. If the level is high, then realize that luspatercept is approved for refractory anemia with ring sideroblasts with thrombocytosis. So if that disease is close to that, that would be what I would utilize to cut down on the transfusion need. Not necessarily in MDS MPN, but obviously there's some data with Revlimid or lenalidomide in people who have low-risk MDS without deletion 5q, and a quarter of them could become transfusion independent. So that's another possibility. Obviously, clinical trials is another, but anemia development can be problematic. I mean, especially if you don't have any of the available agents. Now, there are clinical trials that are looking at this. So, for example, there's a imetelstat, like I referenced in the novel agents. This drug is being explored in patients who have low-risk disease and transfusion dependency. It's also being looked into other MPN states. So, clinical trials may be the way to go if available agents are not successful in reducing or improving transfusion burden.
Thank you, Dr. Shammo. Next question from Sherry. Are there any new protocols with testing donors for stem cell transplant and their genetic mutations?
I think that's something that all transplanters do. They will obtain HLA typing from the patient. They will obtain HLA typing from siblings. They will look at the bone marrow transplant registry. In transplantation, there's always a great need for understanding what the NGS pattern looks like at the time of evaluation. At my center, I tend to get the NGS because obviously if I'm working up a patient, I would want to know what the next-gen sequencing looks like. And of course, at the time of transplant, you may want to look again to make sure that there's no additional mutations that you could target with your treatment. Now, in transplant, there's a great deal of availability to various sources of the donated bone marrow. So it used to be that we looked at sibling, like match sibling donor is the best possible transplant option. But I think those options are expanding because now we're looking at haploidentical donors. You're looking at matched unrelated donors, with presumably from the bone marrow registry, and the outcomes are not all that different for the MUDs. But haploidenticals and all that, or even cord blood transplantation, those are all options that exist, and patients may benefit from that. But again, that is something that requires a discussion with the transplanter, and obviously the input of the MDS PAC would be important.
Thank you. The next question is from Suzanne. She was diagnosed with low-risk MDS in 2011 at age 56 with a bone marrow biopsy, and now she found out that she has the TP53 mutation, but her blasts are low at 6%. They're recommending bone marrow transplant with a bridge to transplant. Is this the way that you think she should go?
Well, I think that's all the information that I know is not enough, but I know that TP53 is not a good mutation to have. I don't know what's the variant allele frequency, like how many of the cells that have TP53, what is the most recent bone marrow biopsy show? Is this still low risk disease? I think monitoring progression of this disorder, I mean, let's say that someone is not transfusion dependent at this point, so I would say, honestly, a clinical trial is very important in this setting, something that targets TP53. And then transplantation is actually, transplant evaluation is good, because we do know that even though hypomethylating agents may work in this subset, like with TP53 mutations, the responses tend to be temporary. So maybe you will respond beautifully to those, but the responses are not long-lived, whereas we know that transplant has a potential for cure. This is a difficult situation, and I'm sorry I can't comment more because I don't have the more data on your disease, like with CBCs and bone marrow besides TP53. So, but I don't think that transplant evaluation is unreasonable in this setting.
Thank you, Dr. Shammo, for weighing in. We have time for one last question from Connie. I have 4 gene deficiencies: 5q minus, JAK2, 7q minus, and TP53. What kind of survival do I have?
So we have 7q deletion and 3 various mutations, including TP53. Is that what I heard?
Yes, 5q minus, JAK2, 7q minus, and TP53.
Yeah, I would want to know if this was something that originated out of prior toxic exposure, like was there previous chemotherapy that was received? Because that is kind of worrisome, to have DEL5, 7, JAK2, and TP53. That's usually indicative of previous exposure to chemo or even radiation, for that matter. And that is kind of a concerning combination, right? That's associated with a higher risk of disease progression. So I would say that would be something that needs to be evaluated again in the context of availability or the potential ability to perform stem cell transplantation.
Thank you so much. That's all the time that we have for questions.
Thank you.
Thank you, Dr. Shammo, for your wonderful presentation and your terrific talk and overview of the disease landscape and the challenges in the field. We appreciate your time. Thank you. That's all the time that we have for questions. For those of you who still have questions, please feel free to reach out to me at ahassan@mds-foundation.org. If you missed out or would like to revisit this webinar, be on the lookout for an email that will provide you with the link within 4 to 7 business days. On behalf of the MDS Foundation, thank you for joining us. This concludes today's program.